It has been an evolving relationship over the years. As the department evolves and changes and gets restructured, that relationship has changed, adapting to the times and needs. 10 years ago, maybe 12 years ago, Medicaid was actually part of public health. Then it was changed, came out of that particular part of the agency and moved as an independent organization under the same umbrella organization where public health is. Now, the relationship is cordial. I can say that it can be way more productive and engaged than what it is today. As in any dynamic relationship in a live organization, is subject to changes. And it needs to change depending on the political needs and the clinical situations of the day, in the public health emergencies of the day, and in the political will to get a particular set of principles and agendas implemented. So it is a good relationship that can be better. And I think that the people who is and has been in charge of both organizations have had best intents at heart. Not always been successful in getting a more productive partnership. In many cases, because even though the objectives seem to be similar and aligned into the big construct of improving the health of the population, the Medicaid group has different type of financial constraints regarding to fee-for-service models and other particular things that do not perfectly blend to a more collaborative relationship. Over the years, there have been many changing priorities and programs where there is a clear overlap between what public health does and the goals that it sets for the state, as well as what Medicaid is trying to achieve based on their mandates and funding. In areas around maternal and child health, which is the core of what Medicaid does, we have had some partnerships that have been really great for our population. We have seen that we have a high rate of smokers in young women that are in our Medicaid program. So maybe twice as high as in the regular population. So we have had some joint approaches from public health. We supported and engaged most of the population in using the Text for Babies approach. We got the same support from the Medicaid side. They paid for the services, not for the Text for Baby, but for the services that are required when people call and have specific needs. And we have a successful partnership on that area. In the last couple of years, we have engaged in some partnerships with direct CMS funding to improve quality in the services that are delivered to pregnant women. And that's one of the key priorities that we see as a public health. So those are areas where we can show that there is a great possibility for enhanced partnerships that actually will address the population health needs of a large population, starting with pregnant women and kids. It has been interesting to create partnerships that are successful and long-term on our structure. Given the political climate that we have been engaged in as a country, living through as a country, as well as that reflection in the state, the financial challenges have been dramatic. But with financial challenges, we have personal challenges. To build partnerships, you need people who staff those partnerships, people who can really set time aside to build something together. And because we don't always have that, it makes it incredibly difficult. At the higher level, so I did work a lot directly with the Medicaid medical director. Under our commissioner, we are an umbrella organization. We had the opportunity to discuss ideas, and they fully embrace the state health improvement plan that the state created, and are looking at ways in how Medicaid collaborates toward those and how to set within those goals for the state specific goals where Medicaid can be the key agency into achieving those goals, and the key agency that will pivot all the transformation of the healthcare system. That is a great place to be, because it will help us drive all the changes that we need toward the future. So it took us a long time coming, but it took us to that place. And now in our state, we have a state innovation model grant where it's co-led by Medicaid and public health. That is the place where we need to be to really affect change and make that transformation the tool for the future changes as we pursue the goals of the State Health Improvement Plan. Medicaid and public health relationships are, I would say by nature, a tricky one because there is a differential in power. They are uneven. Around funding, clearly the lion's share goes toward medical care. And the pressures that the Medicaid agencies have toward performing or delivering or engaging the number of people that they have to with the budget that they have is incredibly complex. When we look at things from a only public health perspective, we want to do more upstream. We need to be able to figure out a way to support Medicaid more in their transformation and help them decrease the cost by working with them and achieving those goals upstream, in the middle of stream, and even downstream through better collaboration and integration of systems. Public health has a unique role in the communities and in our political systems. We can get to be really smart in how to use it so we can advance that joint agenda of improving the health of the population. This is not about a siblings fight. This is about how we really improve what we need to get as a system so we can get our population to be healthier, the services that they are provided in the community settings, in the clinical settings to be a high quality, and help us control the cost so we really improve and provide the services that the population needs at all of the different levels.